Good morning, everyone, and welcome to the opening session of the 2021 National Minority Quality Forum's Leadership Summit on Health Disparities. I'm Monica Hahn, faculty at UCSF's Departments of Family and Community Medicine and OBGYN. I'm very grateful to be here in my capacity as a 2021 NMQF 40 Under 40 awardee. I'm so honored to be here today, and just deepest gratitude to NMQF for the invitation and the encouragement to moderate and engage in this opening session today. So our theme for this year's Leadership Summit is reflective of a critically important topic centered on the ways in which racism affects our health and quite literally makes us sick. We'll hear from two esteemed experts today. First, Dr. Marcella Nunez-Smith, who will give some opening remarks, followed by a deeper conversation with Dr. Cameron Webb. And both are super inspiring physician leaders currently working at the White House in leading health equity efforts in the COVID-19 response. And so we're going to start off with some opening remarks from Dr. Marcella Nunez-Smith, chair of the U.S. COVID-19 Health Equity Task Force and senior advisor to the White House COVID-19 response team. Thanks.
Hello, everyone, and thank you to the National Minority Quality Forum for inviting me to this 2021 Leadership Summit on Health Disparities and Spring Braintrust. I'm Dr. Marcella Nunez-Smith, and I serve as Senior Advisor to the White House COVID-19 response team, and also as Chair of the COVID-19 Health Equity Task Force. And I'm just delighted to be part of the summit's opening session this morning. Last week, we entered a new phase of our vaccination program and our efforts to put this pandemic behind us. Just last Wednesday marked the 200 millionth vaccination and the 92nd day in office. And on that day, the president also called on every employer in America to offer full pay to their employees for any time off needed to get vaccinated and for any time it takes to recover from the after effects of vaccination, with a tax credit to help small and medium-sized businesses achieve this, recognizing the importance of addressing structural barriers to connecting with vaccination. And just a week ago, we hit another important milestone. Everyone 16 years old and older is now eligible for the vaccine. By the end of May, we'll have enough vaccine supply for every adult who wants to get vaccinated. We have thousands of vaccinators and more than 75,000 convenient places. In fact, more than 90% of Americans now have vaccine site within 5 miles of where they live. We recognize access to easy, convenient, and trusted vaccination venues is key for the communities that have been the hardest hit. Knowing that, in the first 3 weeks, the federal government set up and now has expanded federally run programs, including community vaccination centers getting located deliberately in the hardest hit areas, providing vaccine supply directly as well to community health centers, expanding eligibility ahead of schedule to people at community health centers, providing vaccine supply directly to local pharmacies that serve people of color, people living in rural areas, people struggling with poverty, launching hundreds of mobile clinics to meet people where they are, in addition to vaccinating our country's dialysis patients. A commitment to equitable vaccine access means putting resources where they matter. So we talked about locations, but also dollars, and the administration announced nearly $150 million to go to community-based healthcare providers so they can aid in the COVID-19 response. Another $12 million to address rural health disparities specifically. Late last month, a $10 billion investment was announced, focused on our highest risk communities across the country. And this included funding for community health centers, those incredible assets, as well as to deploy community health workers on the front line and to support other local efforts on the ground. At the center of these investments is the recognition that achieving equity is always hyperlocal work, most successful when done in partnership and collaboration with those who are trusted as leaders in their community and faith. And the Community Core is now launched with over 8,000 partners to date, armed with accurate information and resources. I don't have to tell you all, communities of color especially know the consequences of unequal, uneven social, structural, economic, and environmental conditions. Conditions that determine people's risk of illness, drive their ability to access high quality care. They are the outcome of avoidable injustices, historical and contemporary. That's why we're here today, because racism does indeed make us sick. We don't have to think back to Tuskegee and Henrietta Lacks to name injustice in health and healthcare. For many, simply reflecting on our own experiences and those of our loved ones brings to mind instances of receiving subpar care and feeling discriminated against. And of course, we all know the pandemic took advantage of what are pre-existing and long-standing structural and cross-generational systemic realities, essentially involving every sector. The pattern of who has been most affected by the pandemic would be shocking if not for the consistency across conditions, across time. It is our collective work to disrupt these patterns. And the sweeping consequences of the COVID-19 crisis make it abundantly clear that differential health outcomes are intimately tied to differential degrees of access and opportunity. New pathways to economic, educational opportunity must be part of advancing health equity. And along the way, we need to collect the complex data that is necessary to fully understand the scale, the scope of these healthcare disparities, the ones that the pandemic has laid bare, and to find correspondingly meaningful solutions. Equity takes intention. And I know each one of you knows that and practices that every day. As the administration moves forward with the vaccination effort, it's going to be key and already in progress to work with states, local jurisdictions to get primary care providers vaccine doses so more Americans can get vaccinated at their doctor's office, the same way they are accustomed to getting other vaccinations. And also encouraging walk-up availability at pharmacies and other vaccination sites and providing transportation options for those who need them. Again, the structural barriers at the front. More work to do. I do want to say a few words as well about the COVID-19 Health Equity Task Force. The task force is officially launched and is already hard at work to generate recommendations on promoting health equity in the response and recovery. The task force is part of the administration's government-wide effort to identify and eliminate health and social disparities that result in disproportionately higher rates of exposure, illness, hospitalization, and death related to COVID-19. Advisory in nature, the task force brings together non-federal as well as federal members to work together across 4 subcommittees. Those subcommittees are focused on data, analytics, research, healthcare access and quality, structural drivers and xenophobia, and communications and collaborations. The president has asked the task force to make some recommendations on a range of issues. Some include how to equitably allocate COVID-19 resources. We've talked about vaccine, but we have to think about therapeutics, testing, PPE as well, and how to disperse COVID-19 relief funds. Also, strategies for effective outreach and communication to minoritized or marginalized populations and the hardest hit communities, and then how to improve cultural and linguistic responsiveness within the federal government. And on data collection. Data collection is a specific focus of the task force charge, particularly collecting data for the hardest hit communities and identifying data sources that would enable development of short-term targets, yes, for pandemic-related actions, but also for addressing longer-term data shortfalls and challenges so we can be better prepared to respond to future pandemics. And too many people remain invisible in the data. We are making choices every time we allow poor quality data to hinder our ability to push for equity. That must be remedied. All of the meetings of the task force are public facing. And I want to invite you to our next meeting, which will take place this Friday, April 30th, starting at 2 p.m. Eastern. We will be discussing behavioral health with a guest expert joining us to discuss racial trauma. And the subsequent meeting will focus on xenophobia and discrimination and how racism makes us sick. We invite you to watch these meetings live at hhs.gov/live. And I also invite you to submit public comment ahead of time by emailing COVID-19 HETF@hhs.gov. So as I come to a close, I encourage us all to shift our thinking, to be sure that we are drawing always on existing community strengths and assets, that we unite to reject paradigms anchored in deficit models. When we do that, enduring ties can be built, and we will achieve distributive justice. During this National Minority Health Month, I want to reiterate what you already know about equity work. You have to show up, you have to listen, you have to be ready to learn. You have to be humble. Communities are the experts in what they need to thrive. And I want to acknowledge and honor those of you who have been in this work for the duration, for your commitment and tenacity in the face of often disbelief and dismissal. Because of the foundational work you have led, we can all be optimistic that we will indeed meet this moment. My gratitude as well to everyone here for the transformational change you're a part of. The solutions that arise from this event will propel us all forward together in the immediate and with sustainable strategies for equity in the long term. So have a terrific summit. And I'm glad you were able to spend some time in conversation with my colleague and a tremendous health equity champion, Dr. Cameron Webb. So I thank you all again for this opportunity, and please be well.
Wonderful, thank you. A huge thanks to Dr. Nunez-Smith for the really hopeful and inspiring opening remarks, truly rooted in a strengths-based approach that we're all so appreciating right now, especially during these challenging times. So quick before we get on to the next, I just wanted to do a quick housekeeping item. As we continue, just want to remind the audience, please at any time, go ahead and write any questions that you may have into the Q&A box, and we'll plan to leave some time at the end of our conversation with Dr. Webb to get a chance to answer some of those questions. So now it's an honor to be here and joined in conversation with Dr. Cameron Webb, Senior Policy Advisor for Equity on the White House COVID-19 response team, where he's a trusted advisor to give counsel to President Biden on matters related to COVID-19 and its effects, especially on those communities hardest hit by the pandemic. Welcome, Dr. Webb. It's just so exciting to have an administration that values and strives to actualize health equity. This is such an important role that you've been appointed to. So deepest congratulations on that role.
Well, thank you very much, Dr. Hahn. It's great to be with you. And I mean, as a health equity advocate, it's great to be around other people who are passionate about this space and know that we have in a moment where we can really lean into it in a unique way.
Absolutely, thank you. And I've been an enormous admirer of your work, and you know, you've had a really interesting journey to this point. And so maybe we could start off with just what brought you here to this role in this point in time. What does your personal journey look like that really brought you to this incredible leadership role as Senior Policy Advisor for Health Equity?
Well, you know, I guess it starts off really with, you know, growing up, was really passionate about healthcare, wanted to be a doctor. My grandmother was a nurse and got bit by that bug early. When I got to college, I learned about the incredible disparities in our healthcare system, and I became really passionate about figuring out ways to address those disparities. And, you know, my parents are from the South, from Louisiana. We always talked about the role of the civil rights movement in championing change. We talk about, you know, the different tools for justice in our society. And I always found the law to be a unique tool to advocate for justice. And so by the time I was making my way through college, I actually one of my mentors / friends is on today, Dr. Cameron Matthews. But I remember saying, well, what are some of the ways that you can bring these worlds together? And it ultimately for me was medicine and the law. Medicine, that passion for keeping people healthy, the law, that passion for social justice. And so I brought those two together in the combined degree program, finished my 7 years of professional schooling, and at the end of that, did my residency training in New York. Got really steeped in clinical practice, but didn't never take my toe out of that waters of health justice. And so when I left residency, I went to the White House to work for President Obama. At the end of the Obama administration, I worked on the My Brother's Keeper task force. And so really focusing in that work on improving life outcomes for young men of color, and then also worked on the White House healthcare team. And so that was a really unique opportunity as well to help, cross the finish line with the Affordable Care Act and get that work done. That White House Fellowship is a nonpartisan program. So I actually worked for the first 6 months of the Trump administration as well. Very different. And so when you start off a session like this and you mention, oh, it's so nice to have an administration that's focusing in on equity, that's naming it, and that's developing programs and protocols to engage it, I know firsthand how far we were from that over those last 4 years, because I was there when that team landed, and I know that language wasn't a part of their approach. Fast forward, joined faculty at University of Virginia, became the director of health policy and equity. I actually ran for Congress in 2020, and I was the Democratic nominee here in Virginia's 5th congressional district. And my reason for running for Congress was still justice and healthcare. It was always focused in those same areas. And after that race, I came up a little bit short, but that's okay. There's always a plan for you. And I was grateful when the president reached out, when his team reached out about this opportunity, because it's a unique moment that we all have to lean into, and find myself back in the White House, this time focused on COVID and health equity.
Amazing. Thank you so much for sharing your powerful journey. And, no doubt the perfect person to speak to our theme for this summit today. And it sounds like you ended up right where you belonged. And so, much of your background and research has been focused on the concept of allostatic load and really studying the devastating effects that structural racism has on our health and well-being. And I was hoping you could share some of your research and some of how you got to the understanding of how racism literally contributes to making us sick.
Yeah, I mean, for me, I remember a moment when I was during my residency training, and I was walking through a building, and this guy was angry, and he just yelled out, like, "Get out of my way," inward. And I remember feeling my heart rate quicken. I remember feeling my blood pressure seemed to rise, and I was so angry. And I remember, I had to temper that response because, I was not in a setting where I could engage it. Probably shouldn't have engaged anyway, but just the same, I was just like, see, that's not fair that I have to engage with that kind of emotion, that kind of physiologic effect when people engage me with that, or times when a police officer is pulled out behind me, and no matter what's going on, I feel my heart rate quicken, and again, those sorts of things. I say, why is this happening to me? And actually, I'm going to call an audible here. I'm going to pull up a quick slide if that's okay, because I think it tells a story. Can you see the slide okay, Dr. Hahn?
Yes.
Okay, so this slide is a very, very simple way of looking at allostatic load. Not simple at all, just joking. But the thing here is this is that stress response. And this is where I started digging into this work. You start with the brain, and you know that there's corticotropin releasing hormone from the pituitary that goes to the pituitary, you end up with adrenocorticotropic hormone that's released, and that causes the release of cortisol. That's your hypothalamic pituitary adrenal axis, right? So that's one side of that stress response. And on the other side, there's your autonomic nervous system, norepinephrine, and that's your sympathetic adrenomedullary system. And so I raise all this very basic science to say that, on the other end of this is exactly what I experienced. You have your heart rate going up, your blood pressure going up, and that exerts a real cardiovascular effect on people. And if you look at allostasis and allostatic load, and this is the last slide I'll show, if you think about what those stressors are, in this slide it talks about environmental stressors, trauma and abuse, those different and major life events, perceived stresses, whether it's threat, helplessness, vigilance, all of those things come together, and they result in these physiologic responses like the ones that I just showed you. And I'm sure we'll talk about that more over the course of today, but the idea here is that when it gets down to it, you put together that range of physiologic impact. You put together the increases in cortisol, the increases in heart rate, the increases in blood pressure, and you end up with some of the diabetes, the heart disease, the strokes that we see in our communities. You end up with the infant and maternal mortality. You end up with, and certainly on the psychiatric side as well, a tremendous burden on our communities. And so I felt, years ago, I just realized that, as a champion for health equity, you can't ignore the impact that that racism specifically has, because those chronic stressors, people think about, stressors like environments, but no, I'm talking about that perception of racism, that perceived discrimination. And it doesn't matter. One thing that I found in my research is interesting. It doesn't matter the intent of the individual, right? It doesn't matter if they were planning on being racist. It doesn't matter if they didn't realize or recognize that it was a microaggression. All that matters is that impact that it has on the person on the other side of it. And so I think that's what creates such a unique dynamic here, understanding that physiology, understanding that racism truly makes us sick, not just, making us feel like it's like it's morally wrong. It's that it actually impacts our physiology.
Absolutely. Thank you so much for elaborating on such important concepts, great slides, and on your prior research. And absolutely, it really outlines just how real physiologic responses occur due to racism. And these are chronic and weathering effects. And so again, just how fortunate we all feel that somebody with your expertise is having the ear of the White House and serving in this role. And I see in the chat somebody had asked, is this the fight or flight response?
Yeah, sort of. I mean, it's part of that conversation. It is that fight or flight response. But I think there's actually more to it there. So I always describe, people know what homeostasis is, right? It's your body being at equilibrium. Allostasis is the process your body undergoes to get back to normal. So as after you're fighting or flighting, right? When you're trying to get back to homeostasis, your body has to do a lot of things physiologically to get there. And I think that's what we talk about, the number of times that you spend kind of trying to get back. I said I was only going to share 2 slides, but I'm a professor, so I can't help it. There's one more slide that I think will be helpful here. And it's this one. These are dysfunctions in allostasis. So normally you'll have that stress effect and you'll have that physiologic response. And there's a whole bunch of things there. There are cytokines. There's kind of we mentioned cortisol rise, your blood pressure, your cardiovascular system ramping up. That's all part of that stress response. And then there's that recovery phase. And I'm looking at this box at the very top. This is kind of the normal process, the response to stress. Allostasis or allostatic load, it looks a couple of different ways. So this is the repeated hits version, which is if you are constantly being faced with a stress effect, and that's going to cause a physiologic response over and over again. You're spending more time going into that stress response and coming out of it. And that has some wear and tear on your body. The lack of adaptation, this is another dysfunction of allostasis. What happens is that over time, you're supposed to get used to a stressor. The example I usually give is public speaking. If you do it enough, for a lot of folks, over time, it doesn't create as much of a stress response. But for some individuals, and in some instances, you never adapt to those stressors. And I think that you continue to have that physiologic response that's really elevated. The third is just that prolonged response, which is that you have that stress response go up and you don't come back down. You don't recover from that quickly. You hold that revved up sympathetic adrenal medullary system, that revved up hypothalamic pituitary axis, and that's tough on your body. And then finally, an inadequate response, and that's one where I found, and at the time when I was doing this work, it was after spending a couple of years. I did my residency training in New York City. I did my law training in Chicago. And on the south side of Chicago, what I realized is that when kids are confronted by violence every single day, a lot of times we would see one of the two. We would see either that repeated hits phenomenon, or we would see that inadequate response where it just doesn't get their body revved up. And both of them are dangerous to you, right? The fight or flight response is necessary for survival as humans. And so I think it's really interesting. And in some ways, it's really devastating that certain communities, just on the basis of race, are faced with this physiologic impact because we haven't gotten through this dynamic of racism, because we haven't had the conversations we need to have. And listen, you're always going to be faced with stressors, whether they're financial stressors or family stressors. For the Latinx community, we talk a lot about acculturative stress. When people first come to the US, that stress, that chronic stress of being in a new and different environment, and other communities have that as well. But the racial discrimination as a chronic stressor is a unique one, because it's one that we can absolutely address. We can absolutely engage. We can address many of those in different ways, but it's one where we can do better.
Absolutely, could not agree more. Thank you so much for getting more into those details. And yeah, again, so glad that you're in a position now where these really important concepts can be elevated and amplified. And so yeah, if you could tell us a little bit about your role now at the White House as a senior policy advisor for COVID-19 equity, and just about maybe what led to the creation of that role, and how are you kind of taking that role now?
Yeah, I was actually just laughing when you asked the question because the White House is definitely a source of chronic stress. But all that said, so this is a unique role because it's built for a time like this. It's not one of the normal White House components like the Domestic Policy Council or the Office of Management and Budget. This is a separate entity that was created to deal with this specific crisis of the coronavirus pandemic. And so that team is built. At the top is Jeff Zients, who's the director of our federal COVID response. And we all work really in concert. So I work really closely with the vaccine coordinator, the testing coordinator, the supply chain coordinator, the data director, and I'm kind of leading up the equity work on the White House side. And what that means is that in all of our spaces, we have to ask the questions of, well, what should it look like? How do we make sure we do this equitably? And what's been great is since the day that I walked into this administration, that question, it was there even before I landed in this role. People were saying, well, how do we do this equitably? And part of my job, part of Dr. Nunez-Smith as a senior advisor to the COVID response team, part of our job is to make sure that we're adding some technical expertise to the how in terms of the equity piece. I remind folks it's interesting in the White House because I think in some instances government is slow historically, but people feel like if they put their mind to something and they have the resources, they can fix any problem. And that there's often some truth there. But equity work, for those of us who've been in this space for a long time, we know it does not come overnight. This is the kind of thing where you have to invest in the foundation. You have to invest in the intervention in terms of the timely interventions to address the acute problems. But it's something that's it's a whole system that you have to work through. And I think that really driving home that concept has been really important. And I'll tell you, I work closely with other parts of the White House. I work closely with Ambassador Susan Rice and the Domestic Policy Council. And the way she framed it was, she was like, well, your work on the COVID response team doing equity work, that's the sprint. We've got this pandemic that we need to address. And she's like, I want to keep building on that toward the marathon, which is health equity more broadly in our society. How do we make sure that everything we do today to address this pandemic and equity in this pandemic response, how do we make sure that that becomes longstanding health equity work? And I think those are the tasks that we're dealing with. And you heard Dr. Nunez-Smith in her remarks earlier. She talked about some of those vehicles that we're using. I mean, we're trying to get vaccine to as many people as possible. We're addressing some of the vaccine confidence challenges that we know exist for good reason. But we're seeing that more and more people every day are getting vaccinated. Of course, we cleared 200 million shots, but speed goals aren't everything, right? It's more about where are they going, and are they going to people in a way that's fair, right? Are we having the conversations that we need to have? But even beyond that, I think about the therapeutics, the fact that this pandemic has hit communities of color harder. There are more cases. Do we have access to the life-saving treatments that are available out there? And so that's a big thrust of my work. Are we testing adequately in communities of color? And it's not just communities of color. I also do a lot of work around rural communities. I do a lot of work with the disability community, really just thinking about who can and has been left behind in the response to this pandemic. We're looking now even more so to the other aspects of the response, some of the financial response with the American Rescue Plan. Are those resources going to the communities that need them most? I think that's really what an equitable response is. It's really the eyes being trained on making sure that equity was always at the center and that it's measurable, and that we can at the end of the day look back and say, this is how we pressed toward that mark, how we achieved it.
Absolutely. Thank you so much for that background, and just reminding us that about all the different components. Sometimes, when we're talking about COVID-19 and equity, people think only about, vaccine response or only about PPE, but it's such a big gamut of so many different parts that we're needing to think about. And so yeah, as you were starting to discuss, the COVID-19 pandemic has really played such a pivotal role in really exposing and intensifying a lot of the long-standing pre-existing inequities really rooted in structural racism and other forms of historical injustice. And so, given this, what are some of the ways that the Biden-Harris administration and the COVID-19 Equity Task Force kind of envision as ways forward to address just these deep and longstanding racialized inequities that we've seen really laid bare during this pandemic?
Yeah, I love the frame of the question. I think it shows a depth of really understanding what's at stake here. But I'll start off by saying, there are different entities who are doing this work within this administration. And so uh, that's the actual in the White House. That's where I'm leading the health equity work or the COVID equity work. And a lot of our focus, like I mentioned, is across those different dynamics, from the data dynamic, where we have to, if you can't see it, you can't treat it. We need to have accurate data, timely data that tells us where the challenges are so that we can address them. But we're not waiting for the data to act. So then we need to continue to work toward equity on testing, on tracing, on treating, and on vaccinating, right? Those are all key dynamics, making sure that the economic response is there. Those are all parts of what we're doing within the White House. But also there is as you mentioned, the US COVID Health Equity Task Force that Dr. Nunez-Smith leads. That's a really awesome entity because President Biden built that specifically to bring together experts from across the country. And I have to give a nod to the Vice President Harris because this was actually her idea back when she was Senator Harris. She said, we need a COVID equity task force. She introduced a bill to do just that. And that was focused at the time on testing and on understanding what was happening with this pandemic. This was early on in the pandemic. And so this task force grew out of that notion that we should bring together thought leaders, experts, representatives of the most affected communities all over the country, bring them together to be a part of the discussion on the solutions. And that task force, yes, they have their third meeting coming up this Friday, as Dr. Nunez-Smith mentioned, but in their prior two meetings, they've been leading the conversation in so many ways and making key recommendations for how we can do this COVID response better. So I think that that's part of what the administration is doing. It's engaging, I can't tell you how much stakeholder engagement there is, because if you're not listening to people, if you're not engaging with people, talking to people, you're not going to get the answer right. You can sit in the White House or, my basement in Charlottesville, Virginia, my satellite White House office, you can sit in these spaces all you want and think that you've got the right ideas based on your expertise or your experience or what you've seen in your own family or circles. But the truth is you have to go out and talk to people, hear the challenges, see how they align and say, that's actually something we should intervene on. And so tremendous amount of stakeholder engagement has really been one of the keys, partnering well. And those are really key efforts. And so that's part of what we do. But when I mentioned that marathon, again, this administration recognizes COVID, it did lay bare so many of those systemic and structural challenges. And so when you hear the conversation about kind of the new infrastructure conversation that we're having, and you hear people talking about human infrastructure, and you hear people talking about investing in families and communities and the well-being of communities, it's because we're trying to navigate some of those systemic and structural challenges. And people may say, oh, that's not, roads, bridges, waterways. No, but it's just as important as the infrastructure of this nation is its preparedness to have the opportunity for prosperity for its citizens. And I think that's one of the key dynamics here. It's that willingness to step out and say, this is infrastructure to this nation's success, and making sure we move that forward. I think those are some of the conversations that we're very engaged in. I think on the American Rescue Plan implementation, there's one thing I should flag, and that's the public health workforce piece. President Biden mentioned he wanted to add 100,000 people to the public health workforce. But if we rewind the clock to the beginning of 2020, we didn't even appreciate how decimated our public health workforce was. How over the prior few decades, with the lack of investment, we have completely left ourselves wide open for this kind of pandemic to affect our nation in this way. And so the statement was really a resounding never again. And how do we invest in a public health workforce, but not just any public health workforce, not just the same old public health workforce, but really leaning in to community health workers, a community-based workforce that knows the community that they're aiming to serve, really taking people from the community and saying, how can you be a part of ensuring that community's health and well-being, whether that's in the setting of a pandemic or whether that's in the setting of all of the other crises, health crises that have been disproportionately affecting certain communities. And so I think that, that implementation is ongoing. We are making those recommendations for how to spend the $7.66 billion that were allocated in the American Rescue Plan, specifically on the public health side. So there's a lot of work to do. like I said, it keeps me busy, but it keeps all of us busy. I think that so many folks who are on this call today, I've gotten to interact with in my capacity in the White House, because everybody here, and NMQF knows this, Dr. Puckrin knows this, Brandon Garrett knows this, y'all are at the table. This is the conversations that we need to have right now. And so we're so excited to have you as a key thought and implementation partner as we do this work.
Amazing. Thank you so much. And just, yeah, I mean, as you've clearly pointed out, there is so much work to do, and I really appreciate the emphasis on infrastructure and systems change, because we know this virus itself is clearly not racist and doesn't discriminate, but our policies and our social structures do, and this is clearly led to a real change in the public consciousness. Many powerful calls to declare racism a public health emergency this past year, especially, and then really great momentum has been built up now to really hold our health system accountable, to go beyond just lip service and performative allyship, and to truly work towards systems change. And when you talk about infrastructure, I hear a lot of that. And I'm just wondering if you could kind of, just given this momentum of the movement to really address inequities rooted in structural racism, if you could delve a little deeper and describe some of those specific systems change oriented solutions that your team's pushing for in regards to actualizing health equity in the COVID-19 response.
Yeah, I think on the systems change side, you have to understand, on the COVID response side, there's the acute dynamic and there's the more chronic underlying dynamic. So yes, on the acute side, we're absolutely hitting those pieces in terms of testing, tracing, treating, vaccinating. That's going to be a key to keeping people alive, keeping communities to the extent that we can, keep them thriving, continue with the public health messaging, continue building confidence in the response. Those are things that we spend a lot of our time doing. But at its core, we're also spending a lot of our time, and a great example is what we're doing with schools, right? The emphasis on getting kids back in schools and doing so safely, getting teachers vaccinated, that was a priority, making sure that now family members are getting vaccinated so that they feel safe and comfortable getting their kids back in school, giving schools the resources to be able to continue to serve their students day in and day out, especially in the months to come. That's critical because of all that was lost over the last year, all of the opportunity, all the educational opportunities that were lost. I think it's just another great example of how, COVID didn't happen in isolation. Its impact isn't in isolation. If you look at the impact on businesses or the impact on people leaving the workforce, disproportionately, small businesses owned by women and people of color in general were more likely to close in the setting of this pandemic. Disproportionately, women of color left the workplace because of not having, the luxury of some of the buffering that allowed people to have their kids at home during a pandemic and still continue to work, because we tend to be more likely to be those essential workers who have to go in places, and something has to give. Again, the financial resources to allow folks to either have the childcare they need or to make it through until they have an opportunity to get reemployed. That's critical work, and that's how we address this kind of in the acute phase. One thing that really stands out to me is that the moment that we're in, it calls not only for that acute work, but on the chronic side of things, when we dig a little bit deeper, we know exactly where those pressure points are. We know it's our food insecurity, that food infrastructure. We know it's housing. We know it's transportation. These are all the things that we've added up over the years, and we said, wow, look at these incredible disparities. But I think this is where that next phase of the work comes. So when we talk about our infrastructure bill that's being introduced, or we talk about the way the administration is leading there, understand this is built on what we've learned from COVID. It's built on what we know we need in the wake of COVID. Dare I say in the wake of COVID, because we're still in it. But I think that it's all tied together. I think the moment that we're coming through as a nation hopefully gives us an opportunity to recognize, look, we're stronger when everybody is supported in some way, shape, or form. So I think that's a part of it. And one thing that I want to say that is so important is that I deeply appreciate so many of you who are on this call today who have absolutely pushed us every day. We're coming up on the first 100 days of the administration. They always say, you got to push people who disagree with you. You got to push people who agree with you even harder. So I think the way that folks have showed up to be a part of these conversations, and a lot of times we say, well, what can we do? How can you complement our work? How can we work together? That is the conversation we should be having. We need to do these things together. It's so important. And so I appreciate everybody who's pushing us, and don't stop. Keep the pressure on us to overperform, because that's actually what our goal is. We don't know how long we have this opportunity with the House and the Senate and the president and the focus on equity, a part of everyday conversations. Let's use it. And we need your push. We need your energy. We need your passion to press the efforts forward. Keep it up.
Thank you so much. I so appreciate that messaging of inclusivity and elevating of all the different voices. So I wanted to focus on vaccine equity for a moment, just as it's on the minds of so many people right now, as we're just in this race, to reach herd immunity and to kind of beat out these variants. And so much hinges right now on vaccine uptake and on vaccine confidence, as you were mentioning at this time. And often there's just so much of a deficit mindset and this blame narrative that's entrenched in the ways that discussions are often framed about medical mistrust and vaccine hesitancy or deliberation, especially in minoritized communities. And as we've mentioned earlier, as Dr. Nunez-Smith mentioned, from Henrietta Lacks to public health syphilis study at Tuskegee to present day sterilizations in ICE detention camps, the past is absolutely still with us. And, the same systems that have caused harm to minoritized communities in the past are unfortunately alive and functioning today. And so, I've always hated the term medical mistrust, because it puts the onus on the patient for not trusting the medical system, when really it's a completely justified response. And really the onus should be on the medical system to earn the trustworthiness and rectify these past harms. So this question always comes up around vaccines and equity. How is the Biden-Harris administration and your team really trying to change this narrative about medical mistrust and vaccine deliberation around the vaccine for historically marginalized communities?
Well, my good friend Reed Tuckson, I've heard him say this. I've heard other folks say this. If somebody shows up with a needle filled with a substance and says, "I'm going to put this in your body," you should have some questions. I think that's actually normal. It's the way that you should be. So I think that first of all, we have to recognize it is critical for us to get information to answer the questions that exist in communities. The other dynamic that I don't want to glaze past is that there are deliberate disinformation campaigns that become misinformation in certain communities. And so it's not that they're being perpetuated within that community for that intent that we call disinformation. It's that at some point in time, those lines get blurred. And you say, I found this in some dark corner of the internet, but I want to make sure my family is protected. You've got to remember, as you mentioned, that historical context is very much so the present, is very much so the current. And so I think those are some of the dynamics that I always like to raise, is that first and foremost, people are absolutely validated in having some I say vaccine curiosity. I'm interested in knowing more about this vaccine. I want to know exactly what it is. When people use the term vaccine hesitancy, also it's one that frustrates me sometimes, because it's actually three dynamics in one. There's complacency, which is folks saying, I don't really need to get vaccinated. In fact, this virus hasn't caused much damage. My wife and I were in a really rural county in Virginia, just near the West Virginia border over the weekend. And, you could see, because of the way the county is set up, nobody was wearing masks, because they were just like, there's no COVID around here, right? That's that idea of complacency. Doesn't mean there can't be COVID around here, right? It just means that they're just like, I don't really feel like I need to put myself through whatever risk may be present with getting vaccinated. So that's one side of it. There's confidence, which is confidence in the safety and the efficacy of the vaccines themselves, but it's also confidence in the institutions that are asking you, hey, or the institutions that are asking to vaccinate you. That can be your hospitals, your health systems that, prior to the early 1960s were very much so a part of the discrimination. The Hill-Burton Act, that was a big part of what got our hospitals, to a point where they were no longer segregating. They were allowed to build new, they weren't allowed to use federal funds to build new buildings, build new spaces if they were still discriminating by race and ethnicity. That was the tool that administration used to try to drive things forward. So these hospitals, in the lived experience of so many patients, are often the perpetrators of harm, as you described as well. So could be pharmacies, but in different clinics or in different communities, they have different levels of trust and different levels of confidence there. So understanding who is saying they want to vaccinate you. And then finally, trust in the government that's telling you, hey, it's time to get vaccinated. And I think that the politicization of this process has made it really hard for the casual observer to know which way is up when you have, really conflicting messages from administrations. And I think that's where, in this administration, one thing that President Biden was really intent on doing was just taking the politics out of it and presenting the scientists. So you see Dr. Fauci, Dr. Will Smith, you see, Dr. Murthy now, they're out front talking about COVID. It's not President Biden out front talking about COVID. He's getting briefed on COVID every single day. He knows his stuff. I've briefed President Biden. He's very attentive to this. Same with Vice President Harris. The difference is they say the people should hear this from the scientists. We're going to lead with science. And I think that is how we help build back some of that trust. And then the third dynamic, so there's complacency, confidence, and then the last is convenience. And that's having the access to vaccines. And that's a huge dynamic. People often conflate the mistrust with the access. I always tell people, when you're actually saying, here's a vaccine for you, you understand what it is, you understand what's in it, and it's right here in your community available to you, you'd be surprised how many more people we're going to capture. And if there's a building that's on fire, you don't ask the building to make its way to the water. You bring water to the fire, right? And I think that's what we have to work to do in this vaccine campaign, is instead of asking people, make your way to a vaccination location somewhere within 5, 10, 15 miles of you. No, we got to get vaccine to people through mobile units, through community-based organizations, through faith-based organizations, through primary care providers, through emergency departments, through all the spaces where people are already going, make it really capable, really possible for them to get the access. So I think those are some of the keys. I think that it's, there's a lot that goes into that dynamic, but what we found is since December, there has been really consistent gains in that movable middle in terms of vaccine confidence. A lot of folks who were originally saying, oh, we're going to see a lot of hesitancy, if you will, from communities of color, we've seen that number shrink. We've gained so much of that movable middle. We still have, there's a pretty, resistant, up to 1/5 of the population, 20%. So there's a pretty resistant 20%. And what we found is even the data that we have shows that even they can be moved if they're hearing it from trusted messengers. If it's their primary care provider or their pastor or somebody who's saying, hey, this is actually what's true about these vaccines, about their safety, about their efficacy. And really quickly, I just want to give a word about Johnson & Johnson. It's the elephant in the room sometimes, and so, when we talk about the Johnson & Johnson vaccine, on the front end, we said we had 3 vaccines that are safe and effective. And now today, on this week, after everything that's happened with Johnson & Johnson, I can say we have 3 vaccines that are safe and effective. We know that dynamic with the central venous sinus thrombosis plus thrombocytopenia, that's a scary combination. And we don't want to minimize any of those cases, both the confirmed or the likely cases that we've seen, in the context of the 7.2 million shots that have been administered by the time we hit pause. But it's just keeping in mind that every vaccine, every medication has its risks. Our key is understanding what the risk is, who that risk accrues to, and whether it's something that should have us pull it down and say, hey, the risk outweighs the benefit. Here, the benefit far outweighs the risk. The likelihood of injury is so profoundly low that we recognize that it's not worth withholding this really critical tool from communities where it can truly save lives. 100% saving lives, 100% preventing hospitalizations. That's a real key dynamic. And so the damage that COVID can do to you, even if we're talking about blood clots here, the damage that COVID can do to you with clots far outstrips what these vaccines can do. And so I think that's where we just say, we had to lead with the science. We had to wait for that scientific process to play out, for the Advisory Committee on Immunization Practices to take their time and say, we've dug through the data, through the details, and we feel like this is safe. And I think that's where we're building back some of this trust.
Absolutely. Thank you so much. It's really all about really rebuilding that trust and really acknowledging also past harms and moving forward. And I see I know we only have about 10 minutes left, and I wanted to make sure that we get to some audience Q&A as well. Maybe, and one of the questions that had come up in the Q&A was asking to please speak to the unique and striking health equity challenges and COVID plans for imprisoned populations. I wonder if you're able to say a few words about that.
Absolutely. So justice involved individuals have a unique dynamic in this pandemic. And I think that it told us, one, this thing we've been talking about, this new Jim Crow, this epidemic of mass incarceration, it's been bad. It's been unacceptable. But then when people are dying simply because they are in these spaces that they shouldn't be in the first place, well, that's a whole other level. And so I think that it has given additional push to efforts to approach. And I think that a lot of states are kind of taking heed. We can manage folks who've been justice involved in different ways without necessarily incarcerating them, and the damage that causes to families, to communities, and the harm that it puts people at, in the setting of this pandemic. I will say, the federal government oversees the Bureau of Prisons, like federally. And so there are federal prisons, and there's work that we're doing to reduce, the challenges that we're seeing, to reduce the risk of COVID outbreaks, to reduce, and that includes things like, access to personal protective equipment. That includes, making sure we've got really great protocols in place for visitation so that people are safe along the way, but also it includes getting folks out if they don't need to be there, right? And I think there's a whole process that entails vaccination of folks who are incarcerated or justice involved individuals. And so I think that's so important to us, to make sure that every life is highly valued. And so making sure that vaccination plan, that program includes incarcerated individuals as well. A lot of times you would hear early on the emphasis on employees, on prison guards, because that's a congregate setting where there's a higher risk. But to not have incarcerated individuals themselves included in that conversation is I think a huge miss. And so I think that's something that we've been doing from the federal side, and then continuing conversations with all the states, with their own jails and prisons, and saying, here's how we're leading, here's what we think you should be able to do, here's how we can support you in that effort. Because yes, PPEs can be really important, but getting folks vaccinated, getting shots in arms, that's going to be a key. It has a huge impact on communities as a whole. And so, so there's a lot of work in that space. It's one of the really, one of the important dynamics to keep in mind, the role of states in that carceral system, and the role of the federal government, and the connection, but also the separation between the two. But we have been able to use this moment, the resources that we have for COVID, to really, encourage the states, hey, if there's a way to get some of these folks out of jail, out of prison, this is a good time to do it, to revisit, because it keeps communities safe.
Absolutely. Thank you so much for speaking to those really important points. And somewhat related, as far as thinking about all different specific needs for many different groups, including the incarcerated population. So different minoritized groups are experiencing really different and unique harms from this pandemic, but all rooted in different forms of historical oppression that different groups have faced. So I'm thinking back to Dr. Nunez-Smith had mentioned that as part of the COVID-19 Health Equity Task Force, there's a specific committee established to address xenophobia against Asian Americans, for instance, in light of the recent rise in anti-Asian violence. And then also recently, as part of the American Rescue Plan, it's my understanding that the president has allocated specific support for tribal communities and supporting the Indian Health Services to kind of strengthen these targeted responses for different groups. So I'd love if you could share a little bit more about details of some of those specific initiatives and ways that the administration is responding to the different unique intersectional needs of these different groups, and making sure that all these voices are at the table.
Well, I think you kind of named a lot of it. I mean, the idea here is that every single population has to be acknowledged, and we have to identify the challenges that are uniquely facing different communities. And so a lot of times you will hear Black and Brown communities on the forefront of our conversations around COVID, because the impact on cases, on hospitalizations, and on deaths, and just the sheer volume if you look at percentages of the population. But really critically, there were moments in this pandemic where the death rates in Navajo Nation were some of the highest in the entire country, where the Native American communities were really incredibly hard hit. And so I think by mobilizing doses through the Indian Health Services, by making sure that we had additional resources going to IHS to support tribal communities, that was a key. It was a sine qua non of a thoughtful and equitable response, is getting those resources to those communities. Similarly, the rise in anti-Asian violence, the rise in hatred, the xenophobia that we're seeing, and the impact that it has on our communities as a whole, it has no place in our society. And I think that it starts from the highest levels of government, naming it. That's one of the things that's very different from this administration and the last, is just naming, hey, this is happening. This is an injustice. This isn't isolated. This is becoming something that's in communities all over the country for various reasons. And in some ways, it's because of the tone at the top, because of the tone that people were taking at the beginning of this pandemic about certain communities. And so, and particularly the Asian American community. And so I think that it's so important, especially after what happened, we stand up and we say, hey, this may not be directly related to COVID, but we have to find ways to speak out for racial justice. That those efforts around addressing xenophobia, that work from the COVID task force, that came from the president's executive order on racial justice. And so what you see is that the work is tied together. We had an executive order on COVID equity, then there was an executive order on racial justice, and they work together. We recognize that there's a huge racial justice element here. But it's one where, I also mentioned earlier the stakeholder engagement part. We want to be really keyed into exactly what communities are facing, the impacts that are readily apparent on the front page of the newspaper, and the impacts that are more insidious and that we're not seeing every day. We want to make sure that we're getting some insights into those. I'll tell you, in nearly every community, there are great champions who are speaking up and giving us the information that we need to be actionable. Not just us, not just the White House, but also to Congress, so that there are different levers that can be pulled to address some of these challenges. But again, if we don't speak to these particular unique challenges, particularly, I'll give an example. There's a community from the Marshall Islands in Northwest Arkansas, and they're often overlooked, often forgotten, these Marshallese populations in Arkansas, and they are disproportionately hit by the pandemic, right? And if you look at the state of Arkansas as a whole, it's easy for that to get left behind. We have to have data, we have to get micro-targeted, and we have to realize this is a community that's been left behind. We then have those conversations with the state, with the localities, and we say, how can we address this problem? This is happening all over the country, right? There are pockets of communities that are being left behind in the response because they're smaller communities in some instances. And so this is where, we can use that power. We can use the impact of the federal government or our, partners in the state governments to really drive change for these communities.
Thank you so much. Amazing. And we're getting really close to the end of time, but maybe there's another great Q&A question that maybe we could end with, and it's as physicians and health professionals, what is one specific ask we could make of our local legislators to move the needle on health equity?
Well, there's the old statement, all politics is local, all equity work is certainly local. It is absolutely at that local level that equity happens. It's where you're born, grow, live, learn, eat, play, and pray. And all of those things are driven by what's happening in local spaces. And so I would say championing equity work starts in your community. It starts in the schools that are around you. It starts in the roads and your transportation systems. It starts in the jobs that are available, in championing opportunities for folks to have small loans and those sorts of things. Those are really critical pieces, is that in communities, that's where equity happens. It bubbles up and we see these impacts at state levels and federally, but it all starts where you are. So I would say really understanding what your food systems look like. What are your rates of food insecurity locally and what's driving them? The housing dynamics. I live in a community where we don't have enough housing for folks who have lower incomes. We just don't have that kind of sustainable housing. And so what can we do to change that? Affordable housing is a crisis all over the country. So how can you work to address that? I think these are some of the real keys. I think that Yeah, at the local level, that's where you'll actually have your biggest impact. When we say federally, what are the opportunities? What are the big wins for health equity? If you look over the last 20 some years, we had just a handful. If you look in local communities, there was a natural gas pipeline they were trying to put here in Virginia, and a historic African American community in Buckingham County, Union Hill. They fought back. They stopped this pipeline from coming through. They partnered with the Southern Environmental Legal Center, and SELC, and they were able to put together this effort to stop this environmental impact in a historic community of color. That's a racial justice win. That's a health equity win, and it starts at a very local level. We always say we're the change we're waiting for. So I think that if you do that work in a very local way, you'll see the impact it has as it reverberates through our broader society. That's absolutely the place to start.
Thank you so much. Super inspiring. And I think we have time for just one last, for your kind of closing remarks, and just want to pose to you, just taking a strengths-based approach to equity. In your ideal world, what is your vision for how health equity could look in the future if you're wildly successful in meeting your goals?
Well, when we are collectively wildly successful, I think that what it looks like is that no matter who you are, no matter where you are, you have everybody has the same health outcomes. Doesn't mean that there's no diabetes at all. It doesn't mean that we don't still see some differences for different reasons. It's just that everyone had that opportunity to be healthy. It means that everybody had that access to the medicines they need or the healthcare providers they need. But if you go more to the primordial mechanisms, everybody had access to the education they need, access to the food that they needed, not just when they were in elementary school, not just when they were in preschool, even before they were born, because we know these impacts happen and they accrue even before birth. And so my idealized version of a society that's devoid of health inequities is one where really in our communities, we're not seeing food insecurity, we're not seeing housing instability, we're not seeing income inequality, we're not seeing education disparities, we're not seeing issues with healthcare access. I think we have a critical responsibility to shore up our challenges with healthcare access. We still have over 10% of the population who's uninsured. And in this dynamic, with the cost of care being what it is, that's not acceptable. That's not okay in today's society. So these are the things that as a generation of leaders, as a generation of champions, we have to accomplish those goals. If we don't, we are really leaving our society in a tough spot. And I think that we've got the benefit of all of the centuries of inequalities we've watched play out, but also all of the victories we've seen won over the last half century. And so we decide who and how we want to be in the years moving forward. And I do think that, health is in all of our policies. And so I think that, from a health equity standpoint, it's that we start to think about the health impact of all these policies on our communities, that we work intentionally to address them. And I think that, if we focus on those things, we'll find success. It's not going to be easy. We have to be really, really intentional. We have to be really, we have to persevere. That's the only way to put it. But I think we can do it. And I'm excited to work alongside you all to get it done. And thanks for having me this morning. Really appreciated the invitation, the chance to chat with you.
Thank you so much. What an amazing and powerful message to end on. I really, really appreciate your time today and your incredible thoughtfulness and informative work and contributions to furthering health equity. And we're just so grateful for your leadership. So thank you. Thank you for joining us. And I'm sad that, our time for this particular discussion is ending, but I'm also very encouraged and inspired and happy that this summit is going to be so many more sessions and continuing this discussion on this topic. So thank you so much for joining, and thank you everybody for tuning in.
Thanks, y'all. Have a good day.
Thank you.